Great, guys. I'm John Ketzler. I'm the head of anesthesia critical care at the University of Wisconsin in Madison. The topics that were given were a little vague, so I kind of, as I say, this first talk we'll be talking about perioperative care of the septic patient. Second one, perioperative care of the trauma patient. Pre-op evaluation is really desperately important with these patients. The take-home message here is that of the 23 million procedures done annually, high-risk procedures, high-risk patients only represent about 10% of the anesthetic procedures, but they represent 80% of the anesthetic deaths. So it's important to know off the bat what your patient's coming in for and how severe they might be. All kinds of scoring systems, none of these apply. These are for populations. They're really difficult to apply to specific disease states or individual patients. The best indicator is really just the physician. Physicians predict morbidity and mortality way better than any scoring system. The American College of Surgeons and their SCIP program do have a risk calculator online where you just enter in all the information. It'll give you the perioperative morbidity, but again, best indicator is the physician himself. First 6 hours of resuscitation is often coincidental with OR time, so we see these patients all the time. They come rushing up to us from the emergency department or from the ICU. Anytime we do emergency surgery, we have to have a very high level of suspicion that the patient's going to be at the end of their reserves. Our goal, of course, is to find the primary source of their SIRS response. Evaluation, clearly we just want to know how bad the SIRS is and how adequate the resuscitation has been. Early hemodynamic optimization is important. If you can optimize these patients before they go into organ failure, you can increase their mortality by 23%. So you initiate sepsis bundle, and most importantly, get antibiotics on board. There's no evidence that waiting, in the old days we used to wait till we got a sample so that we'd make sure we had a good organism. There's no evidence that waiting is helpful in any way. Getting samples is good if you can get your samples before the antibiotics are given, but getting the antibiotics on board is the most important thing. Clearly, getting broad-spectrum first-line antibiotics on in the first hour is the most important. Our goal of resuscitation, it's to restore adequate oxygen delivery to the peripheral tissues, so we try to avoid pressures if possible. Volume is our first line, but clearly we'll need pressures to temporize, and if they're unstable at all, clearly central venous access is indicated. So here's our first question. Succinylcholine has a higher risk of anaphylaxis than the other relaxants, has a hyperkalemic response after denervation or burn injuries after 24 hours. It does not cause a hyperkalemic response in normal patients or patients with a normal potassium, and it's more likely to cause cardiac arrest in renal patients. Right, and hyperkalemic response is present after burn injuries, denervation injuries. It occurs about 24 hours after the injury, peaks about 7 to 8 days, and can last for months, 16, 18 months. So we have to be very careful with succinylcholine. Risk of anaphylaxis is present with all the neuromuscular blocking agents. They are our primary cause of anaphylaxis in the operating room. Succinylcholine is much more likely than the other non-depolarizers to cause it. Hyperkalemia with succinylcholine can happen even with a normal serum potassium. An intubating dose of succinylcholine in a normal patient can raise the serum potassium 1 to 1.5 milliequivalents per deciliter normally. If they've had some process that causes proliferation of the extrasynaptic receptors, then it can go much higher. And then cardiac arrest is clearly less common in renal patients that are preconditioned to hyperkalemia. Hypotensive septic patient with lactate greater than 3 needs volume. These are our endpoints: CVP 8 to 12, mean arterial pressure of 65 or greater, urine output of 0.5, cc's per kilogram per hour, and a central venous oxygen saturation of 70%. There's no evidence that one type of fluid is better than the other, but as Dr. Kaplan said, the pentastarches, HESPAN, will have a higher incidence of acute renal failure and renal replacement therapy. That is actually dose dependent as well, so we avoid them. Vasopressors, as I say, may need to be used to temporize, especially once the endpoints are met. Norepinephrine is the first line. Vasopressin is used primarily just to decrease the amount of high-dose norepinephrine needed. Surviving Sepsis Campaign recommends dobutamine as the first-line inotrope, but there isn't any evidence that epinephrine is less safe or more harmful or less effective than dobutamine and norepinephrine together. Resuscitation efforts continue as long as we get response. So you want to apply a therapy and assess the response. You want to go back to the assessment. And serum lactate is our best indicator of adequate resuscitation. Supplemental oxygen is helpful even in the patient that's not dyspneic or hypoxemic, just to increase oxygen delivery. And always consider immediate intubation in patients with a decreased level of consciousness. Patients with a Glasgow Coma scale of less than or equal to 8 require immediate intubation. So another question, 7-year-old gentleman, hypotensive, tachycardic, dyspneic, hypoxemic. What's our best induction agent? Propofol rapidly, etomidate rapidly, gradual propofol, or rapid ketamine? So etomidate, very popular, but there's very good evidence that etomidate will increase the risk of adrenal suppression and mortality, even in a single dose. There's a recent meta-analysis in CHEST last July that says that maybe one dose, a single dose of etomidate is safe. I'm not happy with how they chose their studies, and I think for testing purposes, clearly we have to think of an increased risk of mortality and adrenal suppression, even with a single dose of etomidate. Rapid injection of propofol, it's a profound negative inotrope, it's a profound vasodilator. That'll crash a patient that's on the end of their reserves. Gradual injection of propofol is reasonable for a patient who's septic, but not for a rapid sequence induction, which most of these patients require. Ketamine is very effective. It might even have some anti-inflammatory response. So as I say, a lot of options: ketamine, midazolam, slow administration of common agents. Whatever you use, it's got to be very deliberate and stepwise. You have to have a plan in place. And again, you want to avoid etomidate because of the increased risk of adrenal suppression and worsened mortality. So it's well known that lung protective strategy in the ICU is helpful. The IMPROVE trial showed that it's also helpful in the operating room. They took 200 patients. Of the 200 patients, these were intermediate to high-risk patients. They applied lung protective strategy to some and then just regular therapy to others. 21 of the, or 10% of the patients that were assigned to the lung protective strategy had serious complications, whereas almost 30% of those that were not did. So lung protective strategies, even in the operating room, are very important. Post-op, getting patients to the ICU, which patients go to the ICU, they're really no good indicators. You know, advanced age, duration of the procedure, you know, may help lead you, but they're just no good thresholds. Clearly, if they need mechanical ventilation, if they need ongoing pressors. Patients that get sepsis, surgery for sepsis and source control can have huge volume resuscitation requirements and may not be adequately resuscitated when they get back from the operating room and may need continued resuscitation. These patients can need anywhere from 10 to 15 cc's per kilo per hour extra just for third space losses. So you may need to continue resuscitation into the ICU. When they get off, handoff's very important. You want to know where drains are. You want to know how difficult the intubation was. You want to assess the adequacy of the resuscitation. Again, patients may have ongoing needs, and patients that are in heart failure or in renal failure may be under-resuscitated for fear of over-resuscitating them in the operating room. You want to look at pre and perioperative medications. The ones that you really want to pay attention to are the steroids, insulin, anticonvulsants. Very important to continue them. You definitely want to avoid continuing their long-acting antihypertensives in the ICU. Labs and exams are really determined by the procedure that's done in the patient, but you do need to confirm placement of lines and the endotracheal tube because they can be dislodged in transit. You want to do a careful secondary survey when they get to the ICU. Any lines that were placed in non-sterile fashion need to be changed within 24 hours. Post-cardiac patients have a lot of mediastinal tubes. They have epicardial pacing wires in place. Those should be tested and capped if they're not needed. Any permanent pacers should be interrogated if cautery was used or a magnet was used. Last question. Mechanically ventilated patient, which is most likely to decrease the mixed venous oxygen saturation? Septic shock, dobutamine, transfusion of true units, packed cells, or status epilepticus. So septic shock actually prevents offloading of oxygen in the peripheral tissues, and in sepsis, mixed venous oxygen saturations can be elevated. Dobutamine is going to increase your delivery of oxygen, leave oxygen in the periphery less amount of time. That will increase your mixed venous oxygen. Transfusion of red cells will increase your oxygen carrying capacity, also increasing your mixed venous. It's the higher demand of the status epilepticus without the increased delivery that's going to cause that to decrease your mixed venous sats. Again, something to remember, volatile anesthetics, especially for long procedures, can stick around for 20 to 60 minutes. You know, I've had patients come back from the operating room, they've been in the operating room for 20 hours. Those patients are not going to wake up in a couple hours from their anesthetic. If the patient does need to go to the operating room, if they're well resuscitated, if their injuries will allow, they should be evaluated for extubation. Again, all these criteria are met, they're able to maintain and protect their airway, they've had an easy intubation, then these patients should all be evaluated and proceed to extubation criteria. These criteria aren't validated clinically, but there are good consensus guidelines supporting them. Okay? Thank you.